Sorry, I had it open. Page 52, where it says competency 4 critical thinking exercise. And let's look at Susie Q. Okay? So competency 4 is about what? Seizure disorders.
Seizures.
It's really the last neuro competency before we get into renal next week and liver and endocrine. So when we talk about seizure disorders, here's a patient who, I'll read this case study to you, and we're going to start talking about Susie Q. Susie Q is a 23-year-old college student in her final semester of nursing at the local college. She has a history of partial seizures, which then secondarily generalized into tonic-clonic seizures. So partial seizures is one overall type of seizures, right? And the other one is generalized. Okay, so in generalized seizures, the patient does what? The patient loses consciousness. And tonic-clonic generalized seizures are the ones we used to call grand mal. Okay, she's been seizure-free for several years with anticonvulsant drug treatment. So how do most people manage their epilepsy or their seizure disorder? With medications, very good. And she's been seizure-free with her meds. She's come into the school clinic with a bruise on the side of her forehead, a scrape on her left arm, and complaints of muscle aches and a headache. This is page 52 on your study guide. She has missed her morning class and said she slept in after her accident. She reports having a few too many beers last night and does not remember much after leaving the party. Okay, so number 1 says, what further assessment do you need? So she's told you these things. What else do you need to ask and look at?
How much did you drink?
Okay, what's a few too many beers? What else? What other data do you need?
She take her medication.
How long has she had a headache for? Did she wake up with it?
Okay, a little bit more about her headache. I want to know a little, so maybe it was trauma.
Oh.
What does it say about the side of her forehead?
Bruise.
Bruised. Do you want to look at that?
She don't.
I want to look at it, right?
You want to know what drug she's on?
Okay, right. What drugs? What do you mean? You mean what medications does she take for her epilepsy?
Yes.
Okay, what meds does she take for her epilepsy?
What meds did she take while she was at the party?
Yeah, what else did she maybe take when she was at the party? Right. Has she been taking her epilepsy meds as prescribed? Okay.
How often does she have that?
Okay, how often does she have these? It says she's been seizure-free for a few years, but you can ask her that, and she'll tell you that. Yes.
We could also ask her if, because she has been feeling so much better over that period of time, had she stopped taking it?
Okay, great. Has she stopped taking her meds for some reason, or is she not taking them as often? Which would do what? It would lower her therapeutic blood level of her anticonvulsant medications, right? And I want to know which ones they are, which somebody said. What about this accident? What is she talking? Don't you want to know more about that? The accident? I want to know more about that accident. Okay, all right. So this is some good beginning additional assessment. What's the pathophysiology at work? Well, she may have idiopathic epilepsy, right? What does idiopathic mean?
No
cause.
unknown
cause.
No cause, right. Idiopathic, something that's idiopathic means we don't know what causes it, right? Okay, and what does she have related to her seizures? If the last time she had one, you want her to describe it. Does she have an aura, whatever? Okay, but the pathophysiology of a seizure is what? There.
Sudden
Impulse.
Sudden electrical firing, hyperactive neurons to sudden electrical firing. And idiopathic means we don't know why. There are some people we do know why, which we're going to do in a few minutes. We do know the cause, but we don't in her case, let's say. She was born that way. She's had it all her life. We don't know what happened. She was a full-term baby, no increase in intracranial pressure. We just don't know why she has this. But she's managing it and has for 23 years. Okay, so we know that it is electrical firing from the neurons in the brain. How do we measure that? What test do we do? Electroencephalogram, which looks at brain waves, doesn't it? And sometimes then you can see, in her case, a partial seizure. You can see what part of the brain may be involved, right? Okay, I'm going to make a little aside here, and I want to ask some of you from other countries. That's very likely not her case, but you don't know that. What do some cultures believe about seizure disorders?
they believe it's, the person has been taken over by, some evil spirit.
Right, demonic possession
It is
theory.
transferable. We believe that you can. It
And
be
that you can
transferred.
catch it.
Yeah, catch it.
That if someone's having a seizure and you look at them, the evil eye will come upon you and you will catch it. Okay, so those of you who are laughing are not, have heard this before. Okay, so you need to be sensitive to those kinds of things, don't you? If there, even some people in the South who come from Africa have some of those beliefs about devils and evil spirits and demonic possession. Same thing with mental illness, right? People that have, say, hallucinations or delusions. Okay, in this case, seizures. So you have to be sensitive to those things. It's not right or wrong. It's culture. Excuse me, it's culture. And you're not going to say, oh, well, I've seen the EEG, that sort of thing. But that would make it very frightening, not just for the person that's having the seizures, but for the family. And I had a student who said she went home and a man in her church, while she was at a church service, had a seizure during the service, and everyone else ran out of the building. And she was the only one that stayed with him, lowered him to the floor, loosened his tie, put him in an open airway position on his side, and stayed with him until the seizure was over, and then was there to comfort and reorient him. Well, she did, didn't she?
Yeah.
Yeah, she had some scientific training. It happened to be a nursing student here, but it could have been anywhere. And she wasn't fearful because she understood the pathophysiology. Okay, so that's important to teach people so that we can decrease fear and we can help people that have seizures and we can avoid some of the stigma perhaps that comes with some of these beliefs, right? And I did have a student once who told me, she was an older woman, and she said, I understand what you said, Mrs. Zhang, about pathophysiology and the brain waves and the EEG. She said, but I still believe that if, I need to wear my gloves. She took care of a patient with seizures. And she said this and that, I have to put gloves on. And we said, why? He said, well, the saliva might touch my hands and I might catch it. And she just done the course. And this other students are like, no. She's like, that's what I believe. And I was like, well, I have a problem with you taking care of the patient with the seizures. You're entitled to your beliefs. But if you gotta go find gloves to take care of your patient who's having seizures, then I don't think you belong with that patient. And so that's the kind of stuff we really have to confront in a profession like nursing. You're gonna be professional people. So you're gonna be working with maybe a nursing assistant who believes this, which is fine if they believe it, but you can't let it interfere with their safe and advocacy for taking care of the patient. Okay, that's my only soapbox about that. But she really believed that. And she'd already had the lab and the class and everything. And the other students took care of her. All I had to do was kind of go. And they were talking to her about it. Okay, so Susie Q also. So your top priority nursing diagnoses for her. In most patients with seizures, what is our top priority nursing diagnosis?
Safety.
Their risk for injury. Risk for injury, which she may have already had. Now we're going to talk about status epilepticus. Status epilepticus is a medical emergency, which is kind of what this last question does. But mostly it's for number 3, the top priority nursing diagnoses will be related to safety. Safety. Not everybody who has a seizure is going to have status epilepticus or need medical attention. Okay, number 4, what teaching would you implement? And here it says, what barriers to compliance might be expected with this client? Because you're all in peds now, right? So what's it important to know about people?
Developmental.
Their developmental stage, growth and development. Now, let's say she's a very young 23 because her mother has protected her. And she's out on her own now in college. So what's she doing? Drinking beer.
She's being adventurous.
She's being a young person in college, away from mom. So she's drinking a few too many beers. What does alcohol do to your seizure threshold? It decreases your seizure threshold. It makes it more likely that you're going to have a seizure. Does she know, having epilepsy all her life, that she's not supposed to drink alcohol? Probably. So it's not a knowledge deficit. It's a performance problem. It's a growth and development thing. What does she want to do? She wants to be like her friends. She knows she's not supposed to drink alcohol. You can teach her that, but I bet you she knows. Now you have a compliance issue because of her developmental stage. Remember I told you the part of your brain that governs impulse control and judgment isn't fully developed till you're 25? It explains a lot about teenagers and young college kids. Okay. Later that day, number 5, Tanisha T, Susie Q's roommate, comes running in from the cafeteria next to the clinic. Susie Q's been seizing for 5 minutes. The activity stopped before you arrived, but before she wakens, the seizure activity begins again. So now what are your care priorities? She's in what is happening? Yeah, she's in status epi, isn't she? Status epilepticus, which is defined as a seizure that doesn't stop, or it starts right away before the patient has a chance to recover. Most seizures last less than 2 minutes. They start suddenly and they last less than 2 minutes. But now she's into 5 minutes, and as soon as it stops, she starts to seize again. So that is status epilepticus. That's true. So now, what are your top 3 priorities? Well, you do, but first you got to make sure she has a patent airway. Okay, so before you get her to the ER and you get meds in her, which means you have to have an IV, you're going to do airway breathing and circulation. You're going to make sure she has a patent airway. You're going to, people do stop breathing during the tonic phase of the tonic-clonic grand mal type seizure, don't they? But they'll start breathing again during the clonic phase. If she doesn't, of course, that's an even bigger problem. So in this case, you need to do what? You need to call EMS. Even if you're the school nurse, you may have suction equipment, you may have airway equipment, but you still need to get her to a hospital, don't you? To an emergency room. Okay. So this question says, what drugs would be important to have on hand for a seizure-prone patient, which we're going to say in a minute? This slide comes up at the beginning. It also comes up at the end. So this is what we call an advanced organizer. You're going to look at this and think about it, and then you're going to answer it at the end. So when you study, you can see what the answers are. A preeclamptic patient. You study that in Nursing 1030 and OB. Okay, so what is a preeclamptic patient at risk for?
Seizures.
With severe PIH, they can have a seizure. That's a different physiologic event than epilepsy, isn't it? So, a preeclamptic patient, what would we have on hand? What would we give them if they have a seizure from eclampsia?
Magnesium sulfate.
Magnesium sulfate, right? So you have on hand mag sulfate, and you remember the side effects of that, right? I mean, it is essentially a muscle relaxant, but it's only used for eclampsia. Okay, we don't use dilantin for eclampsia. We don't use magnesium sulfate for other kinds of seizure disorders, just for eclampsia. And then the first nursing action in the care of a patient experiencing a seizure, a regular seizure, is safety. So seizure precautions, when a doctor orders seizure precautions for a patient, what is it all about? Safety. Safety. Okay, so hold that thought. All right, this is the definition of seizure. So you said it's a sudden alteration in brain activity. The neurons, the brain waves, the nervous system of the brain becomes irritated. Episode of abnormal motor, which is what? Movement, shaking. Sensory, feeling, right? Psychic, people can have strange feelings, impending doom, deja vu, all these other kinds of strange things. Maybe they smell or see something odd. What?
They can get aggressive.
They can also get aggressive. They can get confused. Sometimes that's from the hypoxia. I had one woman who had lupus, CNS lupus, and she said when she had a seizure coming on, she had an aura, which is what? A feeling preceding the seizure. And in her aura, she smelled old bones in the graveyard. That's how she described her aura. And then she knew she was going to have a seizure. The nice thing about an aura is you can get privacy. She could go in somewhere, lay down, get away from. A lot of people with seizures don't have an aura. They just start into the seizure. Autonomic. What's your autonomic nervous system control? What are the two parts of the autonomic nervous system? Sympathetic and parasympathetic. So if you have sympathetic stimulation, what might change? Pulse rate, your respiratory rate, that kind of thing. Okay, might have some change in vital signs. Maybe the pulse may become labile or something like that. So epilepsy is defined as a recurrent seizure pattern. For whatever reason, that's what the disorder means. Recurrent seizure pattern. So about 75% is idiopathic, which we talked about. And then 25% or so, they actually can identify a secondary causative situation. What are some examples of structural things that could happen that could make somebody seizure prone?
Like
Tumors.
We're not talking about triggers yet.
oh,
I mean an actual problem with the brain.
Alcohol.
Tumors.
Withdrawal.
Tumor.
Tumors, thank you. Brain tumor, which is called a space-occupying lesion in the brain, right? A brain tumor, because it's going to take up space in the brain, and what happens to the intracranial pressure? It'll go up, which can cause a seizure. What are some other space-occupying lesions that can happen in the brain? Trauma, brain injury, head trauma, very good.
Water.
encephalitis.
Encephalitis, okay, that could be an infection. Mostly that would be considered metabolic, but yeah. What about a stroke? A hemorrhagic or thrombotic CBA, or brain attack. A stroke is usually a clot. It could also be a bleed. So head trauma could cause a bleed from a stroke, a bleed from trauma. That increases intracranial pressure. All these are space-occupying lesions. A thrombus, which is a what? A clot from a stroke. Okay. Somebody mentioned water. What if somebody has like an AV malformation or they have hydrocephalus? Because what is hydrocephalus? It's cerebrospinal fluid. Let's try to be scientific here. It's CSF. Hydro means water, but it's cerebrospinal fluid that builds up in the brain because there's some problem, maybe obstruction to circulation or absorption. And if your CSF gets too much, your intracranial pressure increases, right? That's why they do things like VP shunts for hydrocephalus, right? Okay, ventriculoperitoneal shunting. What about some kind of a congenital anomaly, where like a myelomeningocele spina bifida, or hydrocephalus, other birth defects or birth injuries. Actually, an AV malformation, which I mentioned, is arterio, and I should have red, and that's all right. An AV malformation is like an aneurysm. Person's born with an arteriovenous malformation, which means there's a tangle of veins and arteries in the brain. And so the high pressure arterial blood can get into the low pressure venous system, and it can what? Rupture. An aneurysm is where the vessel wall is pouched out, and then it can rupture and bleed. So people can have brain bleeds. They can have aneurysms in their brain, can't they? So any kind of cause of a brain bleed causes increased intracranial pressure. That's another example of a space-occupying lesion. So structural changes are trauma or malformation of some sort. What about metabolic things? What else metabolically can cause a seizure to happen? Alcohol withdrawal, ETOH. Alcohol withdrawal is a big metabolic stressor. Anybody, you see every once in a while you'll see some kid in college who has acute alcohol poisoning. They can have seizures, they can die. Alcoholics can rot their brains, and they can also develop seizures. Even if they don't fall and bump their head, they can still have the neurotoxicity of the ETOH, of the alcohol. And we said that alcohol lowers the seizure threshold. So somebody who already has epilepsy shouldn't drink alcohol. What else?
Hypoglycemia.
Pardon me?
Hypoglycemia.
Ah, lovely. Okay, hyper and hypoglycemia, especially hypoglycemia. So who's at risk of that? Diabetics. People who maybe are taking insulin or even the pills and they're not eating. And their blood sugar gets very, very low. Your brain doesn't store glucose or oxygen. So there's two things that the brain is very sensitive to. Very low glucose and very low oxygen. So another metabolic change would be hypoxia. People get hypoxic enough they can seize, right? Okay, good. Yes, hypoglycemia for sure. We talked about pregnancy. That's eclampsia. I would put infection under there, Desmond, usually with the encephalitis and the meningitis and stuff. It's more of a metabolic thing from the bacteria. Electrolyte imbalances, sometimes, metabolic acidosis, something like that. You mentioned alcohol withdrawal.
Drugs.
Other drugs of abuse. You can get cocaine strokes. People can seize from some of those stimulants, methamphetamines and cocaines. What about waste products that build up? We're going to talk in the next couple weeks about renal failure and liver failure. What kind of waste products build up in renal failure? They can be neurotoxic.
Ammonia.
No, that's liver. So now, what kind of waste products build up in liver failure? Ammonia. Ammonia, which is neurotoxic. That's what causes hepatic encephalopathy, right? Hepatocoma is from the ammonia. So what builds up?
Sodium.
Good. Blood urea nitrogen, uremia. Yes, the BUN builds up. The uremia, which is a protein waste product that builds up in renal failure, right? So things like urea, high BUN and creatinine, things like ammonia, a high blood ammonia level in a liver failure patient. And the last one was some nutritional disorders. You don't see it too much in this country, but there are people that have, say, bad anorexia nervosa, bad eating disorders that get really out of whack, and their proteins can get very low, and they can get protein starvation, and those kinds of things can affect. And B vitamins, right? It's B vitamins, isn't it, that is important for your nervous system. So B vitamin deficiencies. Okay. So in some cases we do know. You'll see people that are head trauma patients, have a history of head injury, and they may be on prophylactic anticonvulsant medications because of their risk of seizures. So you don't really need to be neurologists, but there are two major types of seizures that you saw in your reading. There's general, which is loss of consciousness, and partial, which is a focal area of the brain where they may not be unconscious. Again, a couple types of seizures. These are general seizures. An absence, or absence if you're French, is just a couple of seconds of loss of consciousness with quick return. Patient may have what we call automaticity. Does anybody know what some examples of that might be? That you might see the person doing?
Space out.
They might space out. They might they're not conscious, but they may just glaze over. This may be a child that we think is not paying attention in school. It turns out after an EEG that they have a partial seizure disorder. Or they could be smacking their lips or picking their clothes. Those are examples of automaticities. They're involuntary. They're not doing it on purpose. The tonic-clonic grand mal seizure. What's hypertonic look like? Show me hypertonic.
They get stiff.
Nuchal rigidity, head back. Epistotonos is what it's called, right? The epistotonos position with the arms out, the neck stiff. Okay, and that's the tonic phase. And they'll stop breathing. It's called apnea during the tonic phase. They may initially go, because they're pushing the air out, sort of a Valsalva, forced expiration against a closed glottis. And they're pushing their air out, and then they're getting stiff and they're not breathing. And then they may also be incontinent of stool and urine, right? Then in the clonic phase, what are they going to do? Show me clonus. Show me clonus. Which pencil down? Show me clonus. Shaking, right? Bilateral movement of the extremities. It could be the legs too. Okay. Last 2 to 5 minutes, and then postictally. So preictally, some people have an aura. Preictal is the time what? Before. Postictally would be the time after. Okay? So they may be a little confused. They'll be very sleepy. You may need to let them sleep while their brain recovers. Myoclonic is just the shaking, the clonus. Atonic is a patient who just loses muscle tone. So these are people that are walking around or sitting up and all of a sudden they wake up on the floor. They don't know how they got there. So again, for these patients, what are we concerned about? Safety, risk of injury. Partial seizures, there may not be loss of consciousness. They may have motor, sensory, autonomic, or psychic experiences for a few seconds. Complex partial seizures can be very tricky. They can be pretty severe. They may have automatisms, may speak in jumbled or repetitive phrases, last 1 to 3 minutes. Again, just like with the generalized seizures, there's amnesia for what? For the seizure itself. And they could generalize or become a tonic-clonic seizure. So again, tell me these 3 terms. We talked about, what's this word? Aura. Peculiar sensation preceding a seizure. The next word is preictal. So ictal is the seizure, right? Period before the seizure. And then the last one is post-ictal. So post-ictally, some people may be confused or very tired, and you may need to let them sleep. You may need to reorient them. Always nursing assessment. So here's what you always want to know if a patient has a seizure disorder. The onset. What triggers it? Do they know their trigger? Have they had a history of injuries? Are they injured? Like Susie Q. Don't we want to know about her injuries? It sounds like she maybe fell or had an accident. Whatever that means, we need more information. Frequency is what?
How
How often does she have these? Control means what?
What are you doing?
What are you doing to stop them? Which could be medications. Maybe she's had a surgery. Usually it's controlled with meds. What we call monotherapy, which is one med, but sometimes they need to add a second or a third or a fourth to it, just like we would with blood pressure, for example. And other related history. What could be some examples of related history you might want to know about?
Has she ever had family before?
No, related history is, does she have a history of head trauma? Has she had, birth defects? Is she a preemie? Does she have hydrocephalus? Does she have a VP shunt? All those other possible secondary causes. And then the seizure itself. You always want to know, one of the things you want to know is you want to know how long it lasted. And that's hard in an emergency, isn't it? When did it start? When did it end? Was it 1 minute, 5 minutes? You have to look at your watch or the clock when it begins. And all of these things are what you want to know. And you need to be able to what? Document it. Because if you don't document it, you didn't do it. So you want to know where it started, meaning was it her foot twitching and then it became tonic-clonic? Or did she go right into a tonic-clonic? What was moving? What body parts were involved? Why might you want to know about the eyes, pupils, and head positioning?
Eyes rolling.
It could be relevant to where in her brain the seizure is. The doctor may want to know that. Level of consciousness. Does she lose consciousness or not? You were talking about somebody with partial seizures who didn't have a tonic-clonic seizure, but had some loss of consciousness during a small period of time. Were they incontinent of stool or urine? How long did it last? That's what duration means, right? And level of consciousness. Now, post-ictally, you want to know their level of consciousness. You want to know if they have weakness. You want to know if they're speaking in slurred speech or speech impaired. All that is also relevant to post-ictal assessment. Yes?
Question.
Sure.
If you have a patient and then you were not in the patient's room to witness the seizure, somebody else saw it
Okay.
and told you.
You didn't see
How will
anything?
You didn't say it. They told you your patient had a seizure. How will you document that?
Well, you can't. Well, actually you can. So what would you say? Who reported it? The family member, the tech? Say who reported it.
Patient
And what they
roommate reported.
Or patient's roommate reported that, quote, patient had a seizure. Roommate said that, quote. That's all you can do. If you're not there, and then what are you gonna follow that up with? You're gonna follow that with your nursing assessment. Because you don't just say, oh, okay, thank you. You gotta go in, you gotta assess the patient, you have to put your head to toe assessment, subjective and objective data, that you contacted the physician, what the physician said to do, right?
Well, after a seizure like that, and you get called by the call button that the patient had a seizure.
Right.
Would there be residual effects that you could pick up on and realize, yes, she
Sure.
has?
See, it always depends. There's no yes or no, black or white in medicine, right? But you may be able to get in there fast enough to see maybe either the end of the seizure or the post-ictal state soon enough that you'll see some maybe confusion or whatever, in which case you would document what you saw and heard and felt in your assessment. All you can document that you do is what you assess and you do. But you can say in quotes what someone told you. You'd have to say it was the family or it was the roommate or it was the tech.
In such a case, would an ECG help?
Maybe. You gotta call the doctor. Now you can't order you mean electrocardiogram? You can't order the EKG. You can't order the EEG. But you can report to the physician what happened, and then the physician can give you an order for, say, maybe an EKG. Maybe it's something related to cardiac. We didn't really get into that, but maybe they have atrial fib and they throw a clot and they have stroke and stroke causes a seizure, right? Yeah, so all those things are possible. You're going to do your best assessment. You're going to call the physician and then you're going to document. Now, not every seizure has to go to the emergency department, but the one you're describing, you probably would. Especially if it's something new. So potential triggers. You're here till 11:30. Potential triggers. Desmond mentioned that. So, what would be an example of a pattern of light? What kinds of lights would be neuroirritating enough to trigger a seizure? Strobe lights, flashing lights. A certain pattern of flashing lights will give a normal person a headache. They had a Japanese video game that they had to take off the market because it was triggering seizures in normal children. That's how awful those lights were flashing.
My girlfriend used to have them driving, and
Yep.
and you're driving by trees, and it's like light, dark, light.
Bing,
dark,
bing,
light.
bing, 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 when you're going through those trees and the sun is setting.
That would trigger
Yep,
her
and she
seizures.
had a partial seizure disorder. Yes, and that would be a trigger. Because that pattern of light is very irritating to the optic nerve and to the brain. Yes, good example. It's that strobe light. If you've ever gone to a club where they have that ball thing going all night, you have a headache. And normal people can get seizures from those things, but somebody with a seizure disorder can't be around that kind of light pattern. Certain sounds, illness if they develop, say, certainly if they get a meningitis or encephalitis, but even other illnesses. Stress, well, we all live under stress. They say a certain amount of mild stress is motivating to get you up in the morning, or keep you up all night if you're at work. But, extreme stress that you see no way out of, that's the one that can be really hard. But stress doesn't cause these diseases. Stress doesn't cause epilepsy. Stress doesn't cause Crohn's disease. Stress doesn't cause cancer, right? We know that it can affect the body. And so it still needs to be managed because it can cause exacerbations of problems. Extremes are hot or cold, sensory overload, and ETOH, which of course is alcohol. Okay. Alcohol withdrawal is one of the worst withdrawals. It's even worse than heroin because people do get seizures and a lot of other problems can happen. All right, so complications. We always want to prevent complications. So primary prevention. Primary prevention is what you do so you don't get sick. So of course you want to prevent something that could cause brain injury or something like that. In many cases with idiopathic epilepsy, there is no primary prevention. Yes?
I just want an example of like sensory overload. Would that be like crowds or?
Sensory overload. Think of an ICU. Think of an ICU where the lights are flashing and the ventilators are beeping and the people are coming in and out and you don't have any windows and you don't know what the difference between night and day. And everybody, there's multiple stimulus. There's noise, there's light, there's stress, there's people, there's talking, where your brain can't rest. Pardon me?
Squeaking beds.
Squeaking beds. I mean, it's unfortunately not an uncommon scenario in a hospital. So we do get people in ICUs that, get really irritated brains. They get ICU psychosis, that kind of stuff. That's obviously a brain problem. So just too many things going on, too much stimulation. That's why we're trying to have things like quiet hours in hospitals now, where people actually do have a time to rest, where people aren't bugging them for something. Because you used to go draw blood for people at 4 o'clock in the morning. How did they like that? Not much. You're trying to get the blood down to the lab so the doctor could roll in and see the results. Okay. So status epi we talked about is a neurologic emergency. We'll talk about that again in a minute. If the patient is injured, and then what are some psychosocial complications? Well, if somebody believes it's demonic possession, that's very stigmatizing, right? That would be very scary, so fear. But even other people might feel powerlessness, might be difficult to deal with the medical regimen that they have to follow, the things they have to avoid. So there's the family, if it's a child, right? There's a lot of adjustments to this chronic condition. We're talking in this course about chronic conditions that are, by definition, not curable. But they need to be managed. That's why we have these advocacy groups. The Epilepsy Foundation. Here's one in epilepsy and men's health. Here's one in epilepsy and women. Here's epilepsy and triggers that you should try to avoid. And then a lot of information about support, advocacy, and research. Okay. So all of these things are complications. So if you're preventing complications, that's really the definition of tertiary prevention. The word is still prevention, so you're preventing complications of a disorder. If you're preventing injury in a patient with epilepsy, or you're preventing death, in a patient with status epilepticus, that's really tertiary prevention. Okay. Primary prevention is what? What you do so you don't get sick or you don't get injured. Secondary prevention, what are the magic words? There's really two. Screening, why? Early detection of a condition or disease. Okay. And tertiary is prevention of complications. It didn't ask you to give examples, if you could if you wanted, but it asked you to identify and define. Okay. Most people with epilepsy are managed on medications, medical management with drug treatment, with anticonvulsant drugs, or anti-seizure drugs, or anti-epileptic drugs. You'll see all those terms used. So most people will take it. What's the kind of the gold standard old cheap drug that we use for seizures? No, I'm talking about, yeah. Okay, so while you said lorazepam, I'm going to do something over here. Lorazepam is called what? Ativan, right?
Yeah.
But now the NCLEX is only using the generic names, which is really not fair. But anyway, the PAMs. And we also have diazepam, which is what? Valium. Okay. Now these drugs are not actually anticonvulsant drugs. What are these drugs called? They're called benzodiazepines, right? They're benzos, benzodiazepine tranquilizers. We use Ativan, we use Valium, we use Librium, we use Xanax. They're all benzodiazepines. We use them as muscle relaxants and also to calm people down when they're anxious, right? I had a friend from Boston who was a nurse, Boston Medical Center, where I worked in the spinal cord unit. He sent me a picture on Facebook, and he's got this his car is like a whole big, like 4 feet above the top of his car. You can see this little tiny hole where his car is down in the snow. Boston just got 6 feet of snow. So he says, pass the Ativan, please. It's stressful. Ativan is a tranquilizer, but it's also a muscle relaxant. So we use lorazepam and diazepam in the status epilepticus, in the emergency department. The paramedics have it, the EDs have it. You start an IV, you give Ativan or Valium. Usually it's Ativan. And you stop the shaking, it's a muscle relaxant. Then, you still gotta load them up with anticonvulsant drugs, or anti-epileptic drugs, right? Dilatin, what's the generic name? Phenytoin, right? And there's another one now called Cerebix, and that's fosphenytoin. And that's a prodrug of phenytoin that turns into phenytoin in the body. That's what a prodrug does. And so it's actually a little bit better. They'll load somebody up with some kind of an anticonvulsant, get a therapeutic blood level, right? And then maintain that therapeutic blood level to manage the seizure disorder. So some people never have status epi, they never get a benzo. But they get the anti-epileptic drugs, and there's a whole bunch of them now, right? What are some others? Keppra. You see Keppra for partial seizures especially. Some of these drugs like Neurontin is a seizure medication, but they use it for neuropathic pain mostly, which is gabapentin. So there's a whole bunch of them, and you'll see it on the list, and you'll have it in your reading. We'll talk about Dilatin again in a second. There are some surgeries. Sometimes you'll see, a child went to Hopkins, had half of her brain removed because she had intractable seizures, non-responsive to meds. Most people are controlled on meds, but some people still have seizures even with medications. They don't respond.
I just want you to repeat it right quick. You said that they never had
Some people never have status epilepticus. These are muscle relaxants, benzodiazepines.
Okay.
Hold on for a second. I'm going to talk about the treatment of
Okay.
status epi.
All right.
Okay. What I'm telling you is these aren't anti-seizure meds.
Okay.
These are anti-seizure meds. There's all kinds. Valproic acid. Okay. There's a whole list.
So those are given in conjunction with the AEDs? Or
These are AEDs.
no.
This is only given if the patient is in status epilepticus.
Okay.
Most
only.
patients don't have it.
Okay.
Most patients just get the anti-epileptic drugs. Yes. And you'll see that in your reading. They'll talk about the treatment of status epi. Okay, so surgery sometimes. We're not going to get into that, but some neurosurgeons will treat intractable seizures, especially in kids, because they can seem to make other parts of their brain, take over. They may do a surgical ablation of that part of the brain that's hyperactive. If they can identify the part of the brain where the seizure's coming from and remove it, many people then stop having seizures, but that's very rarely done. And then there's some other things that are more experimental. So again, mostly it's drug therapy. Vagus nerve therapy, they put a pacemaker into the vagus nerve, person gets an aura, hits the button, sometimes it can stop the seizure. Ketogenic diet, especially in kids. What's a ketogenic diet mean to you?
One with more protein.
Like more protein, less carbohydrate.
Right. More protein, and the important part there is very low carbohydrate. That's the Atkins diet. You can eat all the protein and fat you want, you just can't eat any carbohydrates. Some parents feel that the ketogenic diet benefits kids with epilepsy.
I have a question.
There is some research on that.
Status epilepticus, is that only for the tonic-clonic seizures, or could you be in an absent seizure for 10 minutes?
Not usually. I have never heard, it's possible, that's an interesting, look it up and see. I've only heard of real tonic-clonic seizures being status epi. I'm not sure you could be in an absent seizure for 10 minutes, but I suppose it's possible. I've just never heard or seen that. Let's look it up. Let's see if we can find out if other unusual types of seizures can become status epi. What happens generally is it starts out as a partial or some other kind of seizure, and then it becomes, or secondarily turns into tonic-clonic, and then it goes into status epi. So let's think about that. Okay, so of course we're nurses and we have a nursing process, and we want to know what the nursing diagnoses could be based on our assessment, right? So here's some examples. Which ones would be the highest priority if they are impaired? Airway clearance, breathing pattern, which is ABC, and injury. Right. The other things are all things to consider when someone's living with this chronic condition. Nursing care. Okay, so if they have an aura, you can provide privacy. Otherwise, you're going right to bullet number 2. If they don't have an aura, you got to go to bullet 2. What is bullet 2 talking about? It's talking about safety. You're going to move the patient to the floor. They're in giant food. You move them to the floor. You move stuff out of the way. Protect from hard surfaces and objects or pillows, anything that could become airway obstruction. Turn their head and place slightly on one side. That's the open airway rescue position, if you can. Loosen tight-fitting clothing. Suction if needed. What do we not do anymore? We don't shove anything into their mouth.
Yeah, they used to put one out.
I remember wooden tongue blades with a piece of gauze around it and tape.
Back when it was a spoon.
A spoon, right, or even a plastic airway. Well, guess what? Didn't help, made it worse, broke off people's teeth,
You can aspirate it.
aspirated the spoon or that became the obstruction. No, nothing in their mouth. Okay, we know that from research. Evidence-based practice says nothing in their mouth. They're going to start breathing again after the tonic phase ends and the clonic phase starts. They will start breathing again. So we don't want to be shoving things into people's mouths. We can turn them to the side. We can suction if we have it. If you don't have suction, you can't suction. Stay with the patient, call for help. Post-ictally, you provide rest, let them sleep. If it's an unexpected seizure or new seizures or more, frequent seizures, they may need a workup. And here's some of the things they do. So an electroencephalogram, what do you teach the patient? What's it going to be? What's it going to be like? Is it going to hurt? Are they going to stick needles into the brain?
No.
Well, patients don't know they're not going to stick needles into the brain. Okay, so we're going to tell them they're going to put electrodes on their scalp. They may have some goo in their hair. They may need to wash out because we want the electrode to touch the skin. What else?
They need to be still.
They need to lie still, maybe a darkened room.
Take off jewelry.
Take off jewelry and stuff. It's just measuring brain waves, isn't it? They also use it to diagnose brain death in an ICU setting. It's one of the tests for brain death is a flat EEG. If it's one of those sleep deprivation ones, they may have to stay up all night because they want them to sleep. No caffeine, no nicotine, no cocaine, no amphetamine, so no stimulants.
No chocolates.
Pardon me?
So
No chocolate, that's right. Same thing. Okay, they may have an MRI of the brain or a CAT scan if they want to see, look for a space-occupying lesion, a tumor, a bleed, a clot. They may have a PET scan, same kind of thing, positron emission testing. And then labs. They want to know their electrolytes and other chemistries, which includes the liver enzymes and the BUN and creatinine and all of those chemistries. They want to know their CBC. Remember hypoxia. If you don't have enough red cells because you're really anemic, you can get some brain hypoxia. The brain uses 250% more oxygen and more glucose during a seizure. So post-ictally, they're going to be depleted in glucose. That's why for status epi, we'll sometimes give glucose. Okay. So seizure precautions. What are seizure precautions? So a doctor says seizure precautions. What are you going to do as a nurse?
Protection.
Why do you have the side rails?
So
Yes.
they don't smash it, but the book said it could be controversial.
Yeah, I saw places put pads on the side rails. Safety. It's because if they're having tonic-clonic seizure, they won't injure themselves. Okay, what else? Bed low position, locked.
Dim the lights,
Pardon me?
dim the lights for activity.
Maybe, you might be doing that. You're also gonna have them ask for assistance to the bathroom. You don't want somebody to go in, lock the door, and have a seizure.
Oxygen equipment.
Oxygen and suction.
Suction.
Working suction. And I mean, don't just stick it in there, make sure it works, right? I've seen it. Okay, and then the meds. So the most common, what are these meds doing? These anti-epileptic drugs or these anticonvulsants? They're sedating the brain. They're increasing the seizure threshold. They're making the brain less irritable to make it less likely to seize. So people need to take these drugs, and they don't always like them because the most common side effects are what? Dizziness and drowsiness. Clonopin, Tegretol, Depakote, which is valproic acid, Myceline, Zerontin, Neurontin, and then Dilantin, which is phenytoin, are used as anticonvulsant or anti-epileptic drugs. Sometimes they'll still use phenobarbital. I've seen it in dogs. Dogs can get seizures, which is an old hypnotic sedative. Magnesium sulfate only for eclampsia, and then the Ativan and Valium is for status epi to stop the shaking. Okay, I'll let you read these. These are in your readings. We talked about the Epilepsy Foundation. We want people to be mainstream, kids to live as normal as possible, same as adults. They may need to have restrictions on driving if they have recurrent seizures. There's certain rules the MDA has, or the DMV. You want to make sure that they don't get hurt, so sometimes you'll see the kids with epilepsy with helmets, so they don't hurt their head if they fall. Water safety is very important. Door needs to be unlocked. I had a student whose brother was in his 20s, refused to deal with his epilepsy and denied that that he needed to be careful. He swam alone and he had a seizure and drowned.
Yeah.
So somebody needs to be with them if they're going to do some of these things. Maybe side rails on the bed, maybe padded, maybe the mattress on the floor. Waterproof the mattress covers. Why? In case they're incontinent, if it's their kind of epilepsy where they do have that. Now, emergency treatment. If the patient's not breathing or they don't start breathing again, if the seizure's more than 5 minutes, which is status epilepticus, if they have injuries, if it's new onset or increased activity. All right, so status epilepticus. It can lead to respiratory arrest, increase intracranial pressure, hypoxia, brain damage, and death. That's not true with every type of seizure, but status epi is a medical emergency. So in a medical emergency, now what are your top 3 priorities? Or your top 2? Airway and breathing, right, and circulation. So maintain an airway. You can put a mask on them. So you want to have, remember the hypoxia is starting to the brain. 2 lines, 2 IV lines, 1 for meds, labs, that's normal saline because you don't want to have glucose with the meds. You can't really give Dilantin with glucose, can you? It'll precipitate. Dilantin doesn't play nice with others. Even if you're giving it in a tube feeding, a G-tube, you have to have it separate from the other meds. It'll make a big precipitated chunks of glob. Well, it can do that in an IV too if it touches glucose. So you have to have saline if you're going to give phenytoin. Phosphenytoin is used more now in the emergency areas because it doesn't precipitate as badly as Dilantin does. And it's basically the same drug. But you have to be very careful. It has to be given very slowly if it's IV. can't be mixed with glucose, can't be mixed with any other medications. So the first thing you're gonna give is the diazepam or the lorazepam. Usually it's Ativan or lorazepam. That's given first IV push to relax the muscles and stop the shaking. Then they can worry about the anticonvulsant meds and give them phosphatotoin or phenytoin. Okay, what about the D50? Why do you want to give them D50? It needs to be in a separate line because it doesn't mix with dilantin.
Because it can clog the tubing.
Well, it could, but why do you want to give glucose?
Pick up some strength.
Because the brain is using up glucose, right, 250% more during a seizure, so you want to replace glucose. And then you're monitoring the patient. Okay, so do you know? Now, a seizure-prone patient, if the patient has a seizure and it becomes a status epilepticus situation, what meds do you need to have on hand? Or med? What does paramedics have? What does ED give first? Ativan. Stops the seizure, stops the shaking. Then you're going to give the anticonvulsants. Preeclampsia, what med do you have on hand? Magnesium sulfate. Totally different event. And the first nursing action during a regular old seizure, what's your priority?
Safety.
Safety. Seizure precautions are about safety. So what would you do? You would lower them to the floor if they're sitting or standing. Open a tie or something if it's tight around their neck. Move anything out of the way that they might do what? Injure themselves. Right. Okay. Now with status epilepticus, which is now a medical emergency type of seizure, what is our top priority? Airway and breathing. Okay, good. Oxygen, airway, oxygen, and get them to the hospital, like the Susie Q. Now you have a couple other case studies. I want you to look at those over the next week while you're doing your reading. I think they're in the back. They sort of ran together. Page 227 to 233. I don't know why they're in capital letters, we're not shouting. But it's got a child with a febrile seizure. Febrile seizures are only in children between 6 months and 6 years. It's only because their brain's not fully developed and they're sensitive to fever. A febrile seizure is not epilepsy. A child who has a febrile seizure is not epileptic and is not at risk for epilepsy. It's not the same thing. Okay? It's scary for the parents. Page 227. It's scary for the parents, but it's not epilepsy. Some kids are very sensitive to the high fever that spikes quickly. So the main thing they do is just tell the parents to vigilantly treat fevers with ibuprofen or acetaminophen. But it's not epilepsy. And then they'll grow out of it. Now, if the child is 10 years old and they're having seizures, that's different. But a febrile seizure is only in kids 6 months to 6 years old, higher in boys, and it runs in families. Most kids are pretty tolerant to high fevers. Also in that section, you have your seizure precaution skill, and a little algorithm here on page 227. 227. Just a little decision tree, which is called an algorithm. Okay? All right, good job. That's it. Go back over and look at it. Now, I know you didn't study this competency, and I know that's because you had it tested on you. So, nobody came prepared to talk about Susie Q, but you did a good job. And so we're going to try to make sure that we're applying to case studies, that we're using the case studies so you know what to do with real patients in real situations. Some of you've had seizure patients. Be sensitive to people's beliefs and cultures, but you're always educating, you're always reassuring. People need to trust you, but you also have to be sensitive to that. Okay. Questions? Yeah. No, that's just the protocol.
Oh, okay.
You just understand it. Now, we're not checking you off in lab.
If you want to name these
That
things, how do you
is
do
it
it?
is a skills checklist, but we're not gonna check you off.
Apparently you can't have absent seizures in seizure.
You can, and they can just stay that way for 5-10 minutes. Okay.
Yeah, I said it on the Epilepsy Foundation in Chicago, and it was a .org website.
Okay, so yeah, a .org website is usually legitimate.
Yes, hold it.
Yeah, Jessica she Googled the epilepsy.org and found some literature that says you can have other types of seizures, not just tonic-clonic, that stay that type and still become status epi that they can stay for more than 5 minutes. Thank you. So you have your resources, you have things that you can look up, and we want you to do that. We want you to be Googling and looking up things as we talk, so that you can bring more questions like that. Okay? Because you have a different type of seizure disorder, not tonic-clonic. But again, if it doesn't stop in 5 minutes, then it's in the definition. Thank you.
Oh, your laptop?
Alright, guys. Some of you all see in lab.
Petey's bad, she hasn't had a seizure in 3 years, this takes anymore. 3 years.
Because it makes her sleepy and she doesn't like it.
Yep.
I know.